Welcome back to Quick Hits in Laboratory Medicine. I'm Rob Fitzgerald, and for the next 10 minutes, we're going to talk about two very commonly ordered labs, urea and creatinine, and the relationship to renal disease. So why are these important? These are important because typically with renal disease, no symptoms show up until you've lost a full kidney. And that's obviously not good. So you have to lose 50 to 75% of your kidney function before you start to see symptoms. And consequently, a laboratory is going to be very important there to pick up renal insults prior to symptoms developing. It's also important because not only is it used to diagnose renal disease and to monitor renal disease, drugs often are cleared renally, and dose adjustments are made based on estimated glomerular filtration, which is commonly based on creatinine. So people talk about non-protein nitrogenous substance, or Npns, and this table is a list of them. And as you can see, there's a bunch of them in the table. However, we're primarily focused on urea and creatinine. And occasionally we will measure uric acid, oftentimes in the setting of gout, ammonia sometimes in end-stage liver disease, amino acids in the case of inborn errors of metabolism. But urea and nitrogen form part of a routine metabolic panel that's commonly ordered, so it's really important to be able to understand how to interpret values of urea and creatinine. And in our second section, we'll actually talk about disease states and interpreting them in disease states. So for the next 10 minutes, we're going to talk about just sort of basic fundamental principles of urea and creatinine. So our two primary targets are encircled. And urea is actually a fairly simple compound. It has two nitrogen compounds. And the proper term is really urea nitrogen. That's what we measure in the laboratory. Usually it's based on a urease procedure, which frees up the nitrogen, which gets directly measured. So some people call them serum urea nitrogens or BUN, blood urea nitrogen, but they all sort of mean the same thing. It is the major non-protein nitrogenous substance. It's the end product of protein catabolism, and it's a way to deal with ammonia. It's primarily synthesized by the hepatocytes, but it's cleared by the kidneys. And it's useful, and oftentimes I think of its utility in relationship to creatinine and looking at SUN to creatinine ratios. It's freely filtered, but it's also reabsorbed. So it's not going to be a very good GFR marker because it gets reabsorbed. And to be a good GFR marker, it needs to be freely filtered, not secreted, and not reabsorbed. And creatinine fits that picture better, and we'll talk about that in a second. So it's freely filtered, it's reabsorbed, and really the thing to think about on this reabsorption is it depends on flow through the tubules. If you have decreased renal blood flow, you're going to have decreased flow through the tubules, and you're going to reabsorb urea nitrogen. And that's what we would call pre-renal azotemia, because your urea nitrogen goes up because of the reabsorption. The concentration is also diet related, and so if you eat a protein-rich diet, your urea is going to be higher than if you're a vegetarian and you eat a low-protein diet. In fact, that can vary by a factor of 4, so it is quite significant. Creatinine is, we talked about that in one of our cardiovascular lectures when we were talking about the relationship between creatine, which is this substance, and creatinine. Creatine is phosphorylated by creatine kinase. That's the enzyme that we use to look at muscle damage. So total CK activity is a muscle damage marker. We don't measure creatine, but creatine spontaneously breaks down into creatinine. About 1 to 2% of your muscle creatine per day breaks down. So it's a good endogenous marker. It's sort of constantly formed, and it's freely filtered and essentially not reabsorbed or secreted. And those are assumptions that we'll talk about in a minute. So things that are going to influence your creatinine is muscle mass. So this is me as a kid. I was obviously bulked up. And this is me right before I got my hair cut. And obviously those guys have different muscle mass. And those muscle masses are going to have an effect on their creatinine because creatine is breaking down at different rates based on muscle mass. Where does this become important? It becomes important in particular if you have bedridden patients. And in that case, their muscle mass quickly deteriorates and their creatinine concentrations drop. So the concept of clearance is really important, and clearance is a volume of blood that is cleared by a substance in a unit of time. So it's milliliters per minute are the units. And people struggle with trying to remember equations for creatinine clearance. It's really quite simple. You know, what's coming into the glomerulus, since it's freely filtered, it's not secreted, and it's not reabsorbed, goes out in the urine. So in the bloodstream, out in the urine. And what is in, that means concentration of creatinine in the serum times the blood flow in mils per minute coming into the glomerulus equals the creatinine concentration in the urine times the flow. And essentially you get a 24-hour urine, you measure the volume, and then you get mils per minute. The problem with doing this kind of a calculation for creatinine is you need to acquire a 24-hour urine collection. And this has been historically problematic and still is. It's just difficult to get patients to collect 24-hour urine accurately. So we've come up with estimating equations, and we'll talk a little bit about those. So you simplify that equation, flow, that's blood flow essentially, that's how much is being cleared, mils per minute, is going to be showing up in the urine as a urinary concentration times the flow, which is essentially volume per 24 hours. You convert that into minutes, divided by the serum creatinine concentration, gives you GFR, a creatinine clearance. So since it is essentially freely filtered, not reabsorbed, and not secreted, it's a good reflection of GFR. And that's typically how we use it. The freely filtered part, all of it gets cleared. It's not being secreted, so it's not augmenting what you would estimate as the GFR by some tubular secretion. It's actually coming through the glomerulus. And this is where the assumptions sometimes break down. In particular, in end-stage renal disease, where you have high concentrations of creatinine, you get significant secretion. And in that case, you're actually overestimating the GFR because part of it's coming from secretion and not filtration. It's not reabsorbed, and so what's getting cleared stays in the urine sample. There's a variety of different estimating equations. There's the Cockcroft and Gault. There's the MDRD, the CK-EPI, and they all work reasonably well depending on your patient population. There's also some other markers that are being used to measure GFR. Cystatin C is becoming more popular, and it has certain advantages, but in large part, most labs and most hospitals are still using creatinine because that's how the practice is currently based. This is just sort of a summary slide that I wanted to show, and why I like this slide is because it reinforces several things. One is that we're looking at creatinine clearance. This is GFR on the x-axis, serum concentration of creatinine on the y-axis. And what you can see is typically if you've got a fully functional 2 kidneys, you have GFRs somewhere around 120. As you decrease, this is a really small increase in serum creatinine. You don't see large increases of serum creatinine until you've lost a full kidney, which sort of makes sense. People can function with a single kidney, but we want to be able to pick that up clinically by measuring creatinine concentrations and looking for a rise of 0.3 or something like that to indicate significant renal dysfunction. And you can see here we have about 2 million nephrons when we've lost a single kidney. Again, patients don't have any symptoms in this range, yet their creatinine concentration is increasing to an amount that we can measure and differentiate analytically. So that's a quick overview of urea and creatinine, two very commonly measured analytes. And in our next session, we'll talk about how we interpret them in various disease states. Thanks for listening in.